Type. So as I was saying, that the main concepts of physical examinations are shared with what you have already learned in the introductory course, with some slight variation or differences. However, the pediatric age group is somehow considered a very different entity. It has its own specifications, and it's indeed a very special age group. So as in pediatric specialty, the main aim is to ensure health and well-being of the most vulnerable age group of all age groups. So basically in pediatrics, we advocate and care for kids who sometimes cannot communicate, cannot deliver, or complain of what's going on. So it's an art where you can create a way to communicate with kids, either in history or physical examination. The most important advice while doing pediatric physical examination is being patient, okay? In adult physical examinations, we taught you about adhering to the right or correct sequence of physical examination, like inspection, palpation, auscultation, etc. However, in pediatric physical examination, sometimes you might deviate, so you may not adhere to the same sequence because of the difficulties and the hardships that you might face with the pediatric age group. However, you need to fulfill all parts of the physical examination, but sometimes, as I said, you may not follow the same sequence as in adult age group. Anyone interested in becoming a pediatrician? No? Good. So it's somehow considered a not so easy specialty to go through. It needs, as I said, specific skills and patience. However, it's very rewarding. We see miracles before our eyes every day in our practice, like little fighters that can teach you how to cling into life and how to enjoy life and appreciate it. So I hope that you will enjoy your pediatric rotation. Okay, to highlight some differences or some specifications about physical examination of the pediatric age group. First of all, the cooperation of children cannot be guaranteed. So as I said, be patient, be patient, be patient, okay? Sometimes kids are grumpy, not feeling well, anxious, they have stranger anxiety, so you have to be patient and choose the correct time for your encounter and physical examination. Also, the expression or the phenotype of the disease can be influenced by the child's developmental status, which is not seen in adult age group. Also, the clinical signs of the disease may differ from those we see in adults. So we always say that physical examination is all about comparing the norms, like knowing the norms and then comparing what you see, what you observe with the norm that you already know, okay? However, sometimes the normal variations or the norms in pediatric age group can also be different according to the gender and according to the age. So this is something also different from adult age group, where the norms are almost constant in all age groups. Let's take an example, like heart rate. For someone who's just born, a heart rate of 160 is very normal. However, if I see a kid, like a 7-year-old with a heart rate of 160, I will be very anxious, okay? So the approach would be very different. Some chronic illnesses in pediatrics, they may not show themselves like their common symptoms. Let's say with chronic urinary tract infection, patients might present to you with failure to thrive or failure to gain weight. So they may not present with the full-blown typical signs and symptoms of the disease, specifically if we're talking about chronic illnesses. So they might present, as I said, with failure to thrive, failure to gain weight, short stature, etc. So pediatric age groups, so they are divided into multiple ages. So the first month of life, we call it the neonatal age, or we call them newborns, okay? So this is the first month of life. Between a month and a year, this is infancy. We call them infants, okay? Early childhood or childhood from 1 year to 15 years. Some institutes or schools divide it further into early childhood up to 5 years, then middle childhood 5 to 12 years, and then adolescence between 13 and 19 years. Okay, so we can deal with kids up to 19 years of age, adolescence. So, starting with your physical examination, you have to always draw a smile on your face, even if you need to act happy or kind. Okay, so be kind, draw a smile on your face. This helps promote confidence and to break the ice between you and the patient. As with the standard rules of physical examination, always start by washing your hands, introduce yourself properly, gain consent from the parents, because the patient obviously can't give you a consent. Make sure the place is warm. This is more important than it is in adult age group, because temperature changes can influence pediatric age group more than adult age group. Ensure, again, privacy, also adequate exposure. However, again, this is different from adult age group. In adult age group, if I want to pursue a physical examination, I have to have a full exposure of the area that I want to examine. However, in children, exposure may not be done all at once. So expose specific times, one at a time when you're examining them, okay? And of course, try as much as possible to keep the child calm. So, for example, if you want to do respiratory examination of a child, we know inspection, palpation, percussion, and auscultation. This is the normal sequence, right, that you have learned. However, we say sometimes you might leave percussion till the end because it can be annoying for the kid. Kids might cry with percussion, and if they start crying, they won't stop, and you will not be able to auscultate. So auscultation, proper auscultation, needs the child to be quiet and calm. So that's what I said previously, that you may not adhere to the standard sequence of physical examination. So examination is an art in pediatric as it is in adult. We teach you the basics. However, each one of you will build up their own techniques and their own skills, and you will notice that even if X and Z students, they know the same basics of physical examination, their techniques and skills might be a bit different, so there might be personal variation, okay? As I said previously, be patient, be patient, be patient, okay? As I said, vital signs and organ size can be different or variable with age. So liver size, for example, changes with age. So is the heart size. That comes in handy when you want, for example, to palpate for the apex beat. So knowing that the heart size changes, you will know where to feel the apex beat according to the age. So a kid who's 1 year old, the location of the apex beat is different from that of someone who's 8 years old, for example. Again, keep any disturbing procedure or painful procedure till the end if needed to be done. Okay, so same rules. You start with general inspection. So what things in general you need to inspect in a pediatric age group? What would you like to expect, like generally? So maybe the nutritional status of the child. Is he malnourished, for example, obese, overweight? What else would you like to observe? Yeah, this is with a skin examination to notice any abnormal color like jaundice, pallor, cyanosis, etc. Have you heard about dysmorphic features or dysmorphism? So some chromosomal abnormalities or syndromes, they manifest with phenotypes, or what we call them dysmorphic features. So you need to observe for any abnormal dysmorphic features like what we see in Down syndrome, for example, and other syndromes. Again, the color of the child. Is he jaundiced? Is he plethoric? Is he pale? Okay? But the main, like let's say you are in the emergency department or even in the wards, in the clinic, your main, let's say, job is to differentiate between a critically ill kid or a well kid, because the approach will be totally different. So notice any signs of critically ill child, like someone with severe respiratory distress, someone with severe hypovolemia, for example, altered level of consciousness. These needs to be noticed as soon as you get into the patient's room. Okay? You have to comment on the level of consciousness, alertness of the kid. Is he looking around? Is he talking with the surrounding? Is he interacting with the environment or not? As I always say, kids are born to be very mobile and active. So seeing a kid otherwise is alarming. So I'd expect a 3-year-old kid, a normal, well kid, to be like exploring things, running around, walking, talking. Seeing a 2-year-old kid, a toddler, who's sitting still is, for me, is a red flag, okay? Comment on the state of nutrition. Is the kid well-nourished, malnourished, obese, overweight, etc.? You also notice the cry. Is he crying like with a high-pitch cry, low-pitch, or weak cry? This can give you hints on underlying disease or pathology. Any hoarseness of voice, stridor, audible, abnormal sounds. And again, as I said, exposure is important, but it may not be done all at once. Sorry? ايش اعمل بالمايك؟ Okay. تمام. So this is general inspection of pediatric age group. Now then comes the vital signs, which sometimes might be ditched or ignored by some. Vital signs from their name, they are vital. You have to assess the vital signs of pediatric age group. As I said, they vary according to the age, so you have to be age oriented, okay? So vital signs including temperature. In pediatric age group, there are many routes to measure temperature: rectal, axillary, oral, and tympanic or ear route. The more the internal, like with rectal and ear, they reflect more the core body temperature, more than, so they're more precise than measuring the axillary, for example, or the oral. The ranges for the normal temperature also varies according to the route. So talking about rectal, so it's the normal is between 36.6 and 38. So anything above 38 in rectal route, this is abnormal or considered fever. Okay. Otherwise, for measuring it through the tympanic route, the normal range is between 35.5 to 37.5. So anything above 37.5 is considered fever or abnormal temperature or high temperature. For axillary, the normal range is 34.7 up to 37.3. So anything above 37.3 is high fever or fever, okay? So if you notice, I said with rectal, anything above 38. Now, this is core body temperature. As you go outside, the threshold at which you call it a fever becomes less and less, okay? Again, with blood pressure, which is, there's specific indication to why you're going to need to measure the blood pressure. Again, this differs according to age and gender as well. So as a rough estimate, for the normal systolic blood pressure, it's 90 plus age by 2. So if I have a 2-year-old kid, the normal systolic pressure is 2 by 2, 4. 90 plus 4 is 94. So this is the normal or the normal range of systolic blood pressure. Growth parameters, so again, for respiratory rate, for heart rate, again, this is age dependent, as I just previously mentioned. Growth parameters are of great importance, okay? Weight, height, and or length, if the patient is not walking yet, and the head circumference. Measuring growth parameters is not enough to measure or to ask about the weight, the height, the head circumference. You need to plot them in the growth charts, okay? There's specific growth charts, again, according to age and according to gender. So growth charts of female is different from growth chart of male. Do you know why? Why is it different? So the growth rate or acceleration between male and female is different, specifically in the early years of life, okay? So this table summarizes the normal rates of pulse, respiratory rate, and systolic blood pressure according to age. So if you notice, 160 heart rate is considered normal in the first year of life. However, it's up to 100 between 13 and 18. So 160 in an otherwise older kid is considered tachycardia, and you need to look for the reasons. So this is how growth charts look like. As you can see, there are centiles. The highest centile, we call it the 95th centile, and the lowest one is the 5th centile. So if you plot a growth parameter and it's anywhere between the 5th and the 95, this is normal. Below 5, this is abnormal, and above 95, this is abnormal. So again, this is a different growth chart of a female. The same is for the head circumference. You need to plot it on the growth chart, which is age-specific and gender-specific. Okay, so starting with the largest and the most visible organ in the body, which is the skin. So we need to observe for the skin color, if there's any abnormal discoloration, any abnormal pigmentation, either hyper or hypopigmentations. To look for any abnormal rash or exanthems, pallor, jaundice, skin turgor, edema, and the amount of subcutaneous tissue that reflects the nutritional states of the kid. So starting from up below, examining the head. So this is of less importance in adult age group. So do we observe or examine the head in adult age group, like the head shape? So expect the head shape to have been settled down or settled anyhow. So it's not static. It's static or constant. It's not changing as in pediatric age group. With pediatric age group, the head bones or the skull bones are very soft, and this is to allow the incredible brain to grow with age. And it needs a few years for the brain to reach the final size. Okay, that's why the shape of the head, because of how soft the skull bones are, can change due to pressure or specific positions. That's why we always advise moms of newborns to keep changing position of the baby, not to lay flat all the time or at one side all the time. Some common abnormal shapes of the head. Okay, so this is plagiocephaly. As you can see, there is unilateral flattening in the occipital area. This is plagiocephaly, okay? And brachycephaly, this one, there is central occipital flattening. This is in newborns or kids who sleep on their back all the time. This is brachycephaly with asymmetry. So as you can see, it's only occipital flattening on one side, and it's somehow a combination between brachycephaly and plagiocephaly. And we have the last one, which is the scaphocephaly. As you can see, the head is very elongated, out of proportion to the width. So elongated head shape. You have to observe for any bony defects, and I said any abnormal shape or size. Is there microcephaly, small size, that you can comment on by just observation? Because in microceph you might notice it even without measuring the head circumference. So it's the same for the for macroceph or enlarged head circumference. You can tell or comment without even measuring the head circumference. You also have to comment on the hair line. Is it low hairline, high hairline, any patches of hair loss, for example? And you have to also examine the scalp as part of the head examination. Okay, now moving to the eye. So theoretically speaking, we have to evaluate the vision. We don't always have the time in clinical practice to do visual acuity tests for the kids, but this should be part of the standard full physical examination of the pediatric age group. Check for any strabismus, nystagmus, any abnormal conjunctival discoloration like yellow sclera or pale sclera, etc. Look for corneal haziness or cloudiness. Comment on the pupil size and whether it's reactive to light, whether it's symmetrical in shape and size between both sides. And you also, theoretically speaking, you have to pursue fundoscopic evaluation to check for papilledema. Ear examination, we comment on the size of the ear, the location, and the shape. So the location of the ear, we usually draw an imaginary line between the tip of the eyebrow horizontally, and this should be at the level of the tip of the ear. In low-sit ears, as you can see here, so this is the brow, the tip of the brow. If you draw an imaginary horizontal line, the ear is lower than that. So we call it low-sit ears, which is abnormal, and this can be a sign of dysmorphism in many syndromes. You have to also actively examine inside the ear the tympanic membrane to check for any injection, if it's bulging, red, if it's perforated, if there's discharge, any signs of infection or inflammation in the ear canal as well. Don't forget to palpate or feel behind the ear for the mastoid bone to look for mastoiditis. Mastoiditis can be a life-threatening infection that needs to be diagnosed and treated promptly. You know where the mastoids, right? Where to look for it? Do you know? Just behind the ear, okay? Again, now moving down, examining the mouth and throat from the outside, commenting on the lips, the color of the lips. Is there any signs of central cyanosis, for example? Now moving inside the mouth, good luck in persuading the kid to open their mouth and keep it wide open. If you were lucky enough and the kid opens their mouth, you have to be quick and observe as much structures as possible. You observe the buccal mucosa, the area of the soft palate, the hard palate for any ulcers, any abnormal rash. You need to comment whether there is cleft palate, obvious to you. However, sometimes in some cases, have you ever heard of submucosal cleft palate? In some submucosal cleft palate, you may not be able to observe it, so you can't see it. However, you look for hints for submucosal cleft palate, like bifid uvula. Do you know what bifid uvula is? Uvula is that chunk of meat hanging at the posterior aspect of your throat. This is called the uvula. So it's bifid or split into two parts. This can be a sign to look for in submucosal cleft palate, for example. Those kids with submucosal cleft palate, if you put a light, it will be very translucent in the midline, indicating that there might be submucosal cleft palate. So you need to palpate the palate and feel the submucosal palating, okay? Or clefting of the palate. Those kids also with submucosal cleft palate might have nasal speech and recurrent otitis media. Also comment on the voice of the child, the type of their cry as well, any hoarseness, any high pitch or weak cry that you can comment on, you have to mention it. Now neck examination, we need to comment on the shape of the neck, right? In pediatric age group, in some syndromes, you might see webbed neck, where there are skin folds coming from the sides of the neck attaching to the shoulders. So we call them webbed neck, and it's seen in many syndromes like Turner syndrome, Noonan syndrome, and Diamond-Blackfan syndrome as well. Look for any obvious swellings in the neck. Examine the lymph node. I think you have learned how to examine the lymph node during the respiratory. and cardiovascular examination, examine the thyroid gland as well, and comment on the tracheal position because it's part of the neck examination. Now, the nose and sinuses, well, somehow it might be irritant examining the nose, so you have to be careful and gentle. You look for any septal deviation. You comment on the mucosal color. Is it pale mucosa, nasal mucosa? Like in patients with chronic allergies might have enlarged and pale turbinates and mucosa. In acute infections of the nose, you might see congested, red mucosa and turbinates. As you know, pediatric age group, they sometimes tend to be naughty. They tend to insert foreign bodies in their ears and in their nose. So you have to comment whether there's, or look for foreign bodies. Specifically when a child comes complaining of unilateral nasal discharge that cannot be explained by infection or allergy, because if there's an infection like upper respiratory tract infection, the discharge should be bilateral. This is the same for allergy related like rhinitis discharge or rhinorrhea. It should be bilateral. So kids presenting with unilateral nasal discharge, sometimes foully smelling discharge or bloody discharge from one nostril, you need to look for foreign body embedded inside the nasal cavity. And you have to examine the sinuses. So basically you palpate over the sinuses areas for facial tenderness, which is one of the main features in acute sinusitis. Chest examination, this should be familiar to you. So we start by inspection. What do we inspect for with the chest examination? We inspect for chest deformity, pectus excavatum, pectus carinatum, other abnormal signs that you might look for, like those you suspect have or who have rickets or vitamin D deficiency. They present with rachitic rosary or rachitic or beading, which is basically a type of bony prominence at the costochondral junction. You have to also comment on any signs of respiratory distress like tachypnea, retractions, using of the accessory muscles. Be aware that in infants, respiration is mainly aided by diaphragmatic muscles and abdominal muscles, rather than external intercostal and internal intercostal in adult age group and in older pediatric age group. You also observe for any signs of chronic allergic diseases like allergic shiners and salute lines. Do you know what allergic shiners and salute lines are? So patients or kids with chronic allergy, سمعتوا حدا عنده رمد ربيعي أو حساسية الربيع, they tend to chronically itch their eyes. So they develop a kind of swollen fold below their lower eyelid. We call it allergic shiners, and they tend to rub their nose like this all the time, so they develop a horizontal crease over the nasal bridge. We call it salute lines. So we see those findings in kids with chronic allergies. Palpation, what do you palpate for? And respiratory or chest examination, we palpate for chest expansion, superficial tenderness, and emphysema. And as I said, percussion, sometimes it can be very tricky and annoying, so you might leave it till the end. Sometimes you may just skip it. If the patient is very irritable, focus more on keeping the kid calm because you need to auscultate. So we auscultate for breathing sounds. So the normal breathing sounds, what's the normal breathing sound? Bronchovesicular in pediatric age group, yes. So comment on bronchovesicular breathing pattern, any added sounds like wheezes, crepitations or crackles. Don't forget to do auscultation for the base of the lungs bilaterally to observe for, or to listen for any crackles of pulmonary edema, and don't forget to palpate the sacral area to check for sacral edema, right? This is with cardiovascular, mainly cardiovascular exam. One of the signs that you need to comment on also is the Harrison sulcus, as you can see in this photo. So what's Harrison sulcus? Can you see that groove here, bilaterally here and there? So this site is the site of diaphragmatic insertion at the level of almost rib number 6. So this group forms in patients with chronic obstructive disease, like in asthma patients. So the cardiovascular examination, again, it follows the same concepts as an adult cardiovascular exam that we have learned in the introductory course. We start by inspection. You observe for cyanosis, pallor, you observe for clubbing, xanthomatous, Janeway lesions, osseous nodes of infective endocarditis, any scars, any chest wall deformities, any visible pulsation with inspection. We palpate for heave, parasternal heave, and thrill, right, and the epic speed. As I say, the location of the epic speed differs with age. So below the age of 7 years, you find the epic speed at the midclavicular line, almost at the level of the fourth intercostal space. However, after the age of 7, it's similar to adult at the level of the fifth intercostal space. Okay, so you have to mind the age differences when you look for the epic speed. Percussion. What do we need to percuss in the cardiovascular exam? Why did I mention percussion? مين بيعرف؟ زيد تلفاح. What do we need to percuss in cardiovascular exam? ما في متأكد؟ Do we need to percuss for liver span? So hepatomegaly that can be seen in heart failure. So if you suspect that the patient has heart failure, you need to check that there is no hepatomegaly. So you do a percussion to calculate the liver span. Also, when you do abdominal examination, you have to comment on hepatomegaly with palpation to make sure that this, if this goes with an observation of heart failure. So looking for signs of heart failure like hepatomegaly is important in the cardiovascular examination, so you need to mention it as well. And auscultation, we have to auscultate over the valve areas, the aortic, pulmonary, tricuspid, and mitral valve areas. You have to comment on the heart sounds that you hear, S1, S2. Be aware that wide split S2 can be a normal finding in pediatric age group, okay? Comment if there's any gallop or S3, S4 heart sound, any clicks, any murmurs, and you know the maneuvers and where to auscultate. When you auscultate a murmur, you want to make sure what murmur it is, you know the specific maneuvers to be done. Moving to the abdominal examination, again, some slight variation when it comes to the position of the patient. So patients who can sit between the age of 6 months and 3 years, it's best to seat them on their mom's or dad's lap on their knees to keep them calm and still while you're trying to palpate, inspect, and do the percussion for the abdomen. Above 3 years, this depends on how cooperative the child is to lay down and stay still. So you inspect for the abdominal contour. Is it distended? Is it protuberant? Is it scaphoid? Is it symmetrically moving with respiration? Because as we see, as we mentioned in pediatric age group early on, breathing is mainly diaphragmatic and abdominal. So you have to comment on the movement of the abdomen with respiration, any swelling. You have to comment on the position of the umbilicus. Is it centrally located? Is it inverted? Is it everted? And you know the causes for each. Comment on any dilated veins. Again, same concepts of the adult examination. Now, with palpation, again, superficial tenderness, superficial masses, deep tenderness, deep masses, and you do specific palpation for organomegaly, hepatomegaly, and splenomegaly. Now, you know that we need to calculate, as I just mentioned, the liver span. As I said at the beginning of the lecture, the liver size changes with age, okay? So in pediatric age group, it's normal to palpate the liver up to 1 centimeter or almost 1 finger below the costal margin. This can be a normal finding in pediatric age group, specifically if you're examining a skinny patient. However, in newborn, it's normal to palpate the liver edge up to 2.5 centimeters below the costal margin, because it's more distant down to the abdomen, the liver. Regarding the liver span, normally it's 8 plus minus 1.8, but it is less in newborns. In newborns, it's about 4 to 5 centimeters. So you have to also mind the variation according to age. Again, palpate for splenomegaly. We learned in adults that we start from the right iliac fossa, right, and we go obliquely towards the spleen. However, in pediatric age group early on, the spleen enlarges towards the left iliac fossa to start with, and then as they grow up, it starts to enlarge to the right side, as in adults, okay? So if you are examining an infant or someone less than a year of age, if you want to examine for splenomegaly, you don't start from the right iliac fossa. You start from the left iliac fossa and you go up. This is just for infant age group. Percussion for any fluids, ascites, dullness. However, stool impaction in the right side of the abdomen is very common in pediatric age groups. So dullness might be related to stool impaction. And auscultation, we auscultate for bruits and bowel sounds. Okay. The musculoskeletal examination. Okay, so you need to comment on any abnormal postures, any abnormal deformities, any asymmetry, discrepancy in the length of the limbs, mainly the lower limbs, any pain or tenderness upon active or passive movement of the joints. And you have in pediatric age group master the technique for examining for DDH or congenital dislocation of the hip. This exam should be done as soon as the newborn visits clinic for the normal newborn follow-up visit. So we have two techniques, as you can see in the picture. On the left, there's the Barlow maneuver. So what you try to do in the Barlow maneuver is to basically dislocate an unstable hip joint, okay? So you get your newborn on the supine position with a hip flexion at a 90 degrees with a neutral rotation. What you do then is you try to apply a posterior force on the knee, as you can see, pushing the knee posteriorly, while adduction the knees or the legs, you adduct them. And this will, if the hip joint is unstable, will lead to posterior dislocation of the femur head out of the acetabulum. And you will feel what's called like a palpable clunk, or sometimes an audible click. But it's mainly of a palpable clunk that you feel when the femur head is dislocating posteriorly out of the acetabulum, okay? And then comes the Barlow, the Ortolani maneuver. So when you need to place the femur back to its normal location. So again, you get your patient to be on the supine position, flex the hip 90 degrees, as you can see. And then what you do is you lift the femoral trochanter. So can you see this arrow? So lifting the femoral trochanter anteriorly. So it's being pushed anteriorly, following the arrow direction. And you will feel a palpable clunk again when the femur head goes back to its location, or the acetabulum. So positive Barlow and Ortolani means there is highly This is highly sensitive and specific for hip dislocation, congenital hip dislocation. And this needs to be confirmed by an X-ray or early on an ultrasound to be done between the age of 6 to 8 weeks of life. And we know that the untreated DGH is one of the most common causes for lower limb length discrepancy, right? And asymmetrical folds of the lower limbs. Okay, examination of the back. Don't forget the back. We mentioned before. شباب بدون side talks please. شباب ورا. إذا حدا بحس إنه مش interested أو lecture is boring, which it might be for you, you can leave the hall please, but don't interrupt. Back examination is really important. So what do we examine? We look for any asymmetry, any masses, any deformities, and you comment there's scoliosis, kyphosis, lordosis, etc. Any masses that you can palpate, tenderness, any limitation of movement, and spina bifida. Sometimes you can't actually observe spina bifida or like catch spina bifida, but you have to look for signs of spina bifida. Like tuft of hair or what we call it a sacral dimple, which is shown in this picture. So this is a tuft of hair overlying a sacral dimple, which might be a sign of spina bifida or a tethered spinal cord as well. Okay, genitalia or examination of the genitalia is really important. So with the male genitalia examination, you have to make sure that both testicles are well descended. Comment whether there is hydrocele or fluid accumulation in testicles or not. Any hypospadias, which is the ventral displacement of the urethra. So the urethra needs to be located on the tip of the glans. However, if it's ventrally located, this is hypospadias. Look for ambiguous genitalia, and you have to comment on the Tanner stage of pubic hair. Moving to the female genital examination, you have to comment on any vaginal abnormality, discoloration, any masses, sometimes skin tags. Skin tags are common, very common in females. It's considered a normal variant. Enlarged clitoris or clitoris, which might be a sign of or seen in ambiguous genitalia. Fused labia minora, so both labia are fused together. This might be a sign of androgenization or excess androgen secretion. And again, you have to comment on Tanner stage of pubic hair. Anal exam, check for anal patency, if there's any imperforated anus. We will mention now when we move to the newborn specification that for newborns you avoid measuring temperature through the rectal route because if the child has an imperforated anus, you might cause a tear, and this might affect the outcome when during the surgery for the correction of the imperforated anus. So for newborns, we always choose to measure temperature through the axillary route rather than the rectal route. We comment on any fissures, fistulas, hemorrhoids. Usually PR exam is not needed. There's just a few specific indications to why we do rectal examination. Neurological exam, so we observe for any abnormal postures, abnormal movements, any dysmorphic features, which can be part of a syndrome that gives rise to neurological symptoms. You have to comment on the mental status of the patient, how conscious, alert, or oriented the patient is. You have to do cranial nerve examination, check the cerebellar function as we all learned during the introductory course, motor sensory exam. What is special about pediatric age group is the primitive reflexes, okay? So primitive reflexes are a group of involuntary motor movements. They emerge from the brainstem, And the main reason to why God created primitive reflexes, they are kind of for survival or for protective mechanisms for the young age group. However, with time, as the brain develops more, those primitive reflexes start to fade and then replaced with voluntary movement rather than involuntary ones. Don't forget the meningeal signs or examining the meningeal signs. We have the neck stiffness, Kernick's, and Budzinski signs. With Kernick's, you do hip flexion, you flex the knees, and then gradually start to extend. Any resistance or pain indicates meningeal irritation, which might be a sign of meningitis. With Budzinski sign, you flex the neck and observe for any flexion of the hip and knee, which indicates again meningeal irritation. Okay, moving to the newborn examination, which has its own specification. For me, newborn exam is the most wonderful part of physical examination. I have always been fascinated by newborns and their examination. So this is how typically a healthy newborn do look like just after delivery. The first part of the newborn physical examination, we call it Apgar score. Have you ever heard of Apgar score? بعيط أو لا. Part of the criteria, yes, إذا بعيط أو لا. هلا Apgar stands for activity, which reflects muscle tone. P stands for pulse rate. G, grimace, which indicates reflex irritability or how the baby reacts to stimulation. A reflects the appearance, which is the skin color, and R for respiration or respiratory effort. So Apgar score is really important. It's a crucial part of the newborn exam as soon as the baby gets out of the womb. It gives you a quick clinical assessment of the neonate. It should be done at minute 1 and minute 5 because we need to compare. Apgar score can be influenced by any perinatal insults or events. So patients, let's see, with obstructed labor, for example, someone with hypoxic ischemic insult during delivery, they will have a very low Apgar score. And this not only reflects the perinatal insult, but can give you a hint about the outcome of the hypoxia or the perinatal insult. It's a very convenient method to assess newborns. And healthy newborns usually score between 8 to 10. This is the normal score for healthy newborns. The range can be as low as 0 and 10. Okay, so for activity, for example, which reflects the muscle tone, if the baby is flaccid, this is 0, we give them 0. If there's limb flexion, so if you can see this baby, can you see that both upper and lower limbs are both flexed? This is the normal posture of a newborn. So limb flexion will be given 1, and if the baby is actively moving the limbs while flexed, this is active or given 2, which is a full score for the activity. P is for the pulse rate, so absent pulse, or if you can't feel the pulse, this is 0. If the pulse is palpable, but it's below 100, this is given 1 point, and if it's above 100, this is given 2 points. G stands for grimace, or the how the patient or the baby respond to stimulation. So we either do rubbing of their nose, rubbing of their sternum or their back. If the baby stays still, no reaction at all, this is 0. The baby is floppy. If the baby expresses minimal response, like with a kind of a weak cry or a grimace or كشر مثلا, this is 1. But if the baby promptly and actively responds to stimulation, he's given 2. A stands for the appearance, and this reflects the skin tone or the skin color. If the baby is blue, cyanose, totally, central and peripheral, or if the baby is very pale, this is 0. If the baby is pink, however, with acrocyanosis or blue extremities, we give them 1, and if the baby is totally pink, we give them 2. R stands for respiration, so absent active respiratory effort, so the baby has no spontaneous respiratory effort, this is 0. If the baby is showing respiratory effort, but it's very slow and irregular, this is 1. And if the baby is vigorously crying, this is a definite 2, because a baby who's crying has a normal respiratory effort. So cry reflects normal respiratory effort. Crying reflects normal respiratory effort. So if you look at this baby again, so as I said, I would give, I'm not sure whether he's moving actively or not, but both upper and lower limbs are flexed, and I can see that he's fully pink, and he might be crying as well, so I'd expect his respiratory effort to be 2, or given 2 points. Okay, vital signs of the newborns. So we've got the temperature, heart rate, respiratory rate, blood pressure, and capillary refill time. So for the temperature, as I just mentioned, we avoid measuring in other routes. We only depend on the axillary route. The normal temperature, as I said, as with other vital signs, the normal values are different according to the age. So in just newborns, the normal is between 36.5 and 37.5. Anything between 36.5 is considered hypothermia, and the baby should be admitted and warmed. Usually axillary temperature is 0.5 Celsius to 1 Celsius lower than the rectal temperature. Again, we mentioned that the normal heart rate in newborns is between 120 and 160. If the baby is tachycardic, if the heart rate is higher than this, this can be explained by crying, irritation. So you need to make sure that the baby is calm and quiet, or measure the heart rate while the mom is nursing the baby or feeding the baby. In adults, we used to say we count the heart rate or the respiratory rate over 15 seconds and then we multiply by 4, but this is not preferred in pediatric or neonatal examination. So a newborn exam, you have to count for 1 whole minute, okay? Like for respiratory rate, because babies do have what we call periodic breathing. So their breathing in the first mainly few weeks of life, it's not regular. So they might have cycles of bradypnea or decreased heart rate, and then quickly they are tachypneic afterwards. So because of this irregular breathing pattern, or what we call periodic breathing pattern, you need to count the respiratory rate for 1 whole minute. So you can't do 15 seconds and multiply by 4. We don't routinely measure the blood pressure for newborns unless we're suspecting something specific, like if you hear a loud ejection murmur, for example, or an abnormal murmur that's not physiological, you might do the blood pressure reading. Otherwise, we don't need to do that. The capillary refill time should be 2 or less than 3. However, newborns, when they are just born, they might have acrocyanosis. I have just mentioned that, which is bluish discoloration of the extremities, and their extremities might be cold, so the capillary refill might be affected. So it might be up to 4 seconds in their extremities. So sometimes we do measure the capillary refill over the sternal skin, the sternum, or sometimes the auricle of the ear. All right, so again, growth parameters are really important: weight, length, and head circumference. As I said, it is not enough to measure the growth parameters. We need to plot them, and this is a mistake usually all medical students do during clinical rotation. So they jump into just writing the patient's weight, height, and head circumference, and that's it. You need to carry the growth charts around with you. Now you have the privilege of having the growth charts on your iPads, so you can have all the growth charts for different ages and genders on your iPad. So you can just plot the growth parameter, and you need to tell me that the weight, for example, is 10 kilogram, which is on the, for example, 25th centile. So it's telling me that the weight is 10 kilograms is not enough in pediatric age group. So you have to plot the growth parameters on the growth chart. This is really important and might be dismissed by a majority of medical students. For growth charts of newborns, we have different growth charts for prematures. Those who are born prematurely, like before time, like they were born early, we need to plot they have their own growth charts to plot their growth parameters on. So quickly, so the normal infant or newborn weight is between 2.6 and 3.8 kilogram. Anything less than 2.5 kilogram for a newborn is considered low birth weight. Be aware that in the first few days of life, infants might lose up to 10% of their birth weight. So don't panic if that happens. However, they need to catch up and go back to their birth weight at around the 7th to 10th, the 10th days, day 10 post delivery. Okay, so they lose 5 to 10% of their birth weight in the first couple of days, few days after birth, and then they go back to their birth weight at around day 7 to 10 sometimes. In the first month of life, newborns do gain 15 to 20 grams per day. So this is a rough estimate of how a newborn how much they need to gain weight, okay? Because as I said, you compare with the birth weight, okay? So someone who's born with 3 kilograms, and he presents to you after a month gaining, let's say, only gaining 1 kilogram, this is normal. However, if the baby is born with 2 kilograms, for example, and he presents to you at a month age weighing 2.5, this is also normal, because comparing to the birth weight, he has gained around 15 to 20 grams per day. Length, so it's called length now, not height, because obviously they are in supine position. We measure it from crown to heel. The normal range is between 48 to 52, and this is how we measure the length. So from the tip, extending the lower limbs to the heel, from the crown to the heel. Head circumference should be measured again as soon as the baby is born. The way to measure the head circumference from the most prominent bony part of the occiput around to the frontal area. And again, it needs to be plotted on the growth chart. Normally it should be something between 33 to 38 centimeters. And this is how we do measure the head circumference. So this is the most prominent area on the occiput to the frontal area, as you can see here. So again, you have to comment on the posture. So this is a newborn with flexion of upper and lower limbs, which is what I'd expect in a newborn and healthy newborn. Skin. So when they are born, they usually look bright red, usually, or somehow plethoric. Their skin usually is soft. With good elasticity. You might see, so when they are born, during the birth process, they are being squeezed through the birth canal. So when the baby is squeezed, this pressure might cause fluid redistribution, specifically in the presenting part, the part that presents first in the birth canal, which leads to edema, like for example periorbital edema. This is normal and it needs no intervention, and it needs to subside within the first few days of life. As I said, acrocyanosis might be seen normally in otherwise healthy newborns. So cyanosis of the periphery or the extremities can be normal in newborns, because their circulation now is shifting from fetal circulation inside the mom's womb, depending on the placenta, to their own circulation. So at the beginning, blood needs to be shifted to the major organs. That's why you might observe acrocyanosis when they are first born, and then this should gradually improve with time. So this is how a normally looking skin in a newborn is. This is acrocyanosis. Can you see? Tiny, tiny feet. You have also, so the vernix caseosa, or the vernix, it's a thick, creamy, yellowish to white layer that covers the baby skin while inside the womb to protect the baby from the irritation of the amniotic fluid. We know the amniotic fluid is basically urine, right? And urine is very acidic and irritant. So God created this layer to protect the baby. You might observe it covering the whole body of the baby. Sometimes it might be only seen on folds, like as you can see here, axillary area. Okay, there is a continuous debate on whether the baby needs to be washed right after delivery to get rid of the vernix. Some debate that it should be washed off. Others suggest that it shouldn't. However, recent studies showed that vernix is very beneficial, specifically in the first 24 to 48 hours of life. So try to avoid, we advise moms nowadays to avoid سبب ايش؟ هم a layer to protect the baby's skin from irritation inside the womb, like the amniotic fluid irritation, lubrication and protection from irritation of the amniotic fluid. So recent studies have shown that you should avoid washing this vernix layer specifically in the first 24 hours of life. Studies have shown that this vernix plays an important role in maintaining a normal skin pH and a normal flora, okay, which might protect later on from allergies, eczema, even asthma and food allergies. Mongolian spot. So back in time, if a baby is born with a Mongolian spot, which is a black or bluish discoloration or spots seen on the back of the baby, the anterior trunk, sometimes the upper limbs. In our culture, it used to be linked to mental retardation because of the name Mongolian spot. However, this has nothing to do with mental retardation, okay? Mongolian spots do emerge because melanocytes migrate to the dermal layer of the skin. And this is a very benign condition. It needs no intervention, and they do gradually subside or fade with time without any treatment. This is how Mongolian spots look like. Can you see this bluish sacral discoloration here on the buttock as well? Here on the upper back, and also can be seen on the upper extremities. However, be careful because the appearance might be confused with bruises, okay? So you have to make sure that the baby has no coagulopathy or other bleeding somewhere else or any signs suggestive of bruises. It's very common to see a desquamated baby after birth. We call this desquamation of the baby's skin. So basically peeling off skin over bony prominence, and it's very prominent during the first month of life. Again, this is considered a normal variation, and it needs no treatment, and it subsides spontaneously. Can you see the desquamation here? Peeling of skin over the abdomen. Okay, we observe as well for physiological jaundice. We will have a lecture devoted just for neonatal jaundice. So we have physiological jaundice or yellowish discoloration of skin, and we have pathological jaundice. Usually physiological jaundice does not appear in the first 24 hours of life. So jaundice in the first day of life, this is most likely a pathological type of jaundice. So comment on jaundice when examining a newborn. Some other benign conditions that you might see, we call it milia. Milia is a small white to yellow spots seen mainly over the nose, sometimes the cheek, the chin, forehead, due to accumulation of secretions of the sweat glands and the sebaceous gland that cannot still drain or because they have not fully developed, and they again disappear in the first 2 weeks of life when those glands are fully developed and can drain themselves. This is how physiological jaundice looks like. This is a jaundiced baby, another jaundiced baby. However, sometimes it's difficult to comment on jaundice in dark-skinned babies. It's very hard to evaluate dark-skinned babies for jaundice. So we have to depend on the sclera and the creases of the hand sometimes. This is how milia look like. Can you see the white spots? Here and there. So this is a totally benign condition. It needs no intervention. Do you know the name of this? We call it angel kiss or salmon patch or stork beak. So this is a collection of capillary blood vessels close to the skin. So capillary blood vessels. This is again a normal variation. Okay, examining the head of a newborn. As I said, the skull bones are very soft, allowing the baby's brain to grow and develop. And that's why also we've got sutures and we've got fontanelles. So we need to have open fontanelles, anterior and posterior, to allow the brain to grow and expand. So we have the first one, the anterior fontanelle, anteriorly located. It's diamond in shape. It connects the two parietal bones with the frontal bone. Usually the anterior fontanelle closes around the age 12 to 18 months. So up to 18 months is acceptable. However, if a baby, for example, has got severe vitamin D deficiency or rickets, the fontanelle might remain open longer than or beyond the 18 months of age. The width of the anterior fontanelle is about 2 to 3 centimeters in width and 3 to 4 in length. Moving to the posterior fontanelle, it's much smaller, located posteriorly between the parietal and the occipital bones, and it closes as early as the almost second month of life. So between roughly 6 and 8 weeks of life. Caput succedaneum. Have you ever seen a newborn's head that looks like this? حد عمره شاف newborn who looks like this? So as I said, when babies are born during the birth process, they are being squeezed through the birth canal. So this pressure applied on their presenting part. So if the occiput is the presenting part or the face is the presenting part, this will lead to edema and swelling of that presenting part due to fluid accumulation with a pressure. However, because this is something external, it's edema, redistribution of fluid, it does not cause any complication. It's benign, and it can crosses the midline, moves between sutures, and it can cross the midline. We need to know this point because we're going to compare it with cephalohematoma that we're going to discuss in a few seconds. So caput succedaneum, as I said, pressure-related edema or fluid redistribution. It's a benign condition, and it can cross the midline, as you can see here. So if you press on it, edema is very obvious. So this is how to tell this is edema or not. And the fact that it's homogeneous, crossing the midline sutures, also points to caput succedaneum, which is different from cephalohematoma or cephalohematoma, which is basically periosteal collection of blood. Why does this blood collect below the periosteum? It's due to rupture of blood vessels between the skull and the periosteum. Okay? So there's a group of very tiny capillaries between the skull and the periosteum. during birth due to pressure, specifically if there's instrumental delivery like vacuum delivery or forceps delivery. This will lead to rupture of those tiny blood vessels, leading to subperiosteal blood collection, or what we call a cephalohematoma. Because this is subperiosteal, blood can never cross the midline sutures. Okay, so this is how it looks like. See? So it's here, but it's not crossing the midline. It's not reaching there. So this is how it's different from caput saxedinum. So the management of cephalohematoma basically depends on how big it is. Usually cephalohematomas are really small. They tend to self-resorb with time. They need no intervention. However, they might cause, according to their size, some complication, because this blood basically will be hemolyzed and resorbed, so they might cause jaundice if it's large. And sometimes they might also cause pressure if it's also large, periosteal pressure. Okay, eye examination. As I said again, edema of the upper eyelids is very common in vaginally delivered babies. Usually the question in clinic, when is my baby's eyes color gonna show? Usually all newborns do have gray kind of eye color. The final or the eye color tends to settle at around the age of 6 months, between 3 and 6 months. You have to comment on the pupils. Are they symmetrical in size and shape? You have to check for reflex to light. So pointing light toward the pupil should constrict, right? And you should be able to see what we call the red light reflex. After birth, babies can't cry. They have no tears because the lacrimal glands are not yet fully developed. So this is a normally looking eye. So this is how the red reflex should look like. Both pupils are equally reacting to light. They are both red, same size. Here, there's unilateral red reflex. Here, this is abnormal red reflex. We see that in when we have corneal cloudiness, as we see in cataract. This is a baby with congenital cataract that might be caused by what we call torch infection or congenital torch infection. You will learn about this more. This is a normal eyelid edema, upper and lower eyelid edema. Also, this is a reassuring kind of finding. This is subconjunctival hemorrhage, again due to the pressure on the presenting part during delivery. Some subconjunctival small capillaries might rupture, causing subconjunctival hemorrhage. This is self-resolving and needs no intervention. Again, you have to comment on the ears, their size, shape, location, the presence of cartilage. Some syndromes, the cartilaginous part of the ear auricle is lost. And part of the newborn exam, we have to do a hearing test. So this should be part of the regular newborn examination. This is a normally looking ear, this one as well. Nose, we check for nasal patency. Usually when we are examining newborns, we insert a very small nasogastric catheter or tube just to make sure that both nostrils are patent. You might observe a whitish mucus discharge, which is normal in newborns. This is a normally looking nose, and this is a nose with dislocated nasal septum. Neck examination. Usually newborns, they do have short neck with thick skin, with loads of skin folds. Comment whether there is webbing of the neck, any masses or lesions. This is how a normal newborn neck looks like. Mouth examination. As I said previously, we have to check for cleft palate, cleft lip, I mentioned about the submucosal cleft palate and what signs to look for. There's a normal finding in newborn, we call it Epstein pearls, which is basically white shiny spots on the palate, the hard palate of the babies. This is normal and they tend to disappear with time. This is how they look like, Epstein pearls, those ones. This is totally normal. This is a picture of cleft palate. This is cleft lip. Now moving to the abdomen. Newborn abdomen is usually cylindrical in shape, slightly protuberant. You have to comment on the umbilicus, centrally located. When we examine the umbilicus, we cut, when the baby is delivered, just delivered, we cut the umbilical cord. Sometimes we do what's called delayed cord clamping. Studies have shown this protects against anemia. So it's just somehow we allow more blood to flow to the baby before we cut the placental cord. And then when we cut it, we observe inside of the umbilicus, there should be 2 arteries and 1 vein. Okay? So bluish white in color at birth, as I say, 2 arteries and 1 vein. In some syndromes or sometimes in renal anomalies, they might have only 1 artery and 1 vein. Okay? So if I examine a baby and notice only 1 artery and 1 vein, I might ask for example, a renal ultrasound to rule out renal anomalies. So this is a meconium stained umbilical cord. Do you know what meconium means? So the fetal stool inside the womb is called meconium. Okay, so it can stain the umbilical cord, the skin, the nails. And that's it. Thank you very much. Any questions? أي أسئلة؟ الله يعافيكم.